Good morning, everyone. I wish we could all be together in San Diego, but I look forward to spending the next bit of time with you talking about managing myelodysplastic syndrome, or MDS, in the wake of a global pandemic. I certainly think we all know this has been quite an unprecedented year, and I'll show you some specific cases and experiences I've had here in Baltimore taking care of this patient population. These are my disclosures. So today I'm going to share with you the true story of a COVID positive patient who was densely transfusion dependent and review how that sorted out for her. Then I'm going to speak about a patient who continued to get active therapy throughout, though much different than he had been prior to the pandemic. And then we'll discuss being aggressive in a young patient with myelodysplastic syndrome whose disease was quite high risk. And I'll show you some of the initiatives that are ongoing as we currently continue to manage MDS in the wake of a global pandemic. So moving ahead, this is actually a picture from today that I took from our website. And Johns Hopkins has led some of the initiatives from the Center for System Science and Engineering in following the global cases. This happens to be November 11th on the day that I'm recording this, but just to give you a flavor that there's always a place you can go and look. And the number of cases has continued to escalate. And looking at it by country, some of you are in the US, perhaps here with me, some of you in other countries throughout the world, and really have a flavor of how this is truly affecting all of us throughout the world. Specifically here at my home institution in Baltimore, this is the admissions through the spring. And I'll just simply show you the blue that we really saw the number of admissions really start to surge over the course of the spring. And about the time I was asked to give this talk, these numbers were started to go down. I think, unfortunately, probably by the time you view this in early December, we may be going back up. Following the COVID positivity has become a part of our day-to-day life in the oncology center. This affects not just our myelodysplastic syndrome patients, but really understanding how the resources for our entire hospital system need to marry both oncology needs as well as the COVID-specific needs. And this is just another snapshot that I've tended to follow very regularly here in Baltimore. But specifically as it relates to the myelodysplastic syndrome patients we're going to speak about in a moment. Over the course of our season here of COVID-19 at Hopkins, only about 10% of the patients who had a COVID positive diagnosis also carried a concomitant diagnosis of cancer. And less than 1% in our hospital have also had a myeloid malignancy. That includes MDS, but also AML. And I think that we may see this change over time, but it is something we're tracking. So specifically as it relates to oncology and our MDS patients, we've had to utilize innovative ways to take care of these patients, as I know you all have throughout the world, as this has changed the face of healthcare. So we initiated an urgent care space. We called it Urgent Care 2 or the BioMode. And this was an urgent care where patients who were considered persons under investigation could be rapidly assessed. And the reason this was so important, and I'll show you in a moment for our patients with myelodysplastic syndrome, is this was an infusion place, even if a patient was COVID positive, where they could continue to receive their oncologic care. And I think that this was really important for us at the time. This initiative still continues, but the volumes have not been as high in this area as they had been earlier in the summer a few months ago. They may increase again as rates again are rising at the time I give this presentation. Something we had not had here in Baltimore before was a drive-through shot clinic. And literally, patients who needed either their bloods drawn or their perhaps erythropoiesis stimulating agents drawn could simply drive through, pretty much stick their arm out the window and have a much faster healthcare interaction experience and still get what I felt they needed. This has been really loved by patients because it's more convenient and, at least in Baltimore, saves the parking price, which is important to many patients. Some of the challenges that are ongoing have been physical distancing. Our waiting rooms probably look very different, as do yours. The chairs are now 6 feet apart, among other things. Probably the hardest part of caring for patients, especially with myelodysplastic syndrome, but other diseases as well, have been the visitor restrictions in the oncology center. My clinic is still not permitted to have more than one patient in the visit unless it was an initial new patient encounter. And this has been really hard for patients with all diagnoses, but especially for MDS patients who might be more advanced in years, have hearing problems, need a child or a spouse to really help them comprehend their diagnosis and work through a therapeutic paradigm. We have been fortunate here to have consistent PPE use. We've also had a lot of changes in teaching and rounding. We're utilizing Zoom quite a bit more, as I know you all are, and this is an example of it. And we're using it both for patients and for teaching for our trainees. Something to show you here is all that we're going through specifically for the MDS patients, and I'll use a couple illustrative cases as we go forward. Mrs. S is a real patient. She'd had a diagnosis of myelodysplastic syndrome for a little over 2 years. She was 81 years old at the time that this story began. When I met her, she had already been failed by hypomethylating agents. She had had 8 cycles of azacitidine without much change in her transfusion burden, which was 2 units of red cells every 10 days to 2 weeks, and it had been like that for about 6 months. She shared her time between 2 of her children's families, and she had traveled to New Jersey in the spring of 2020 from one of her homes here in Baltimore. And unfortunately, she returned home in Febrile. She ended up having COVID. She was RNA positive, and she was admitted for nearly 3 weeks. Despite her advanced years, she actually managed to do all right. She never required ICU level care, and her functional status was probably about a Karnofsky of 70% even at baseline, but she returned about to that at the time of discharge. This was a woman who required transfusions consistently, and how could we keep this up in the context of the pandemic? So there's a lot of ways to think about this, and certainly individual patients are different. This was a family and a patient who were extremely determined that she would continue her care despite this diagnosis of COVID. She was fever-free, and her respiratory symptoms were negative. However, other requirements by our hospital to return to treatment were to have 2 negative COVID swabs at least 24 hours apart. This was followed by some of the CDC recommendations. Our own infectious disease colleagues were instrumental in making guidelines for our hospital. And once these rules were in place, it became a real challenge to care for patients like Mrs. S because she was not able to have, as you'll see, 2 negative COVID swabs 24 hours apart. So I mentioned the BioMode unit a moment ago. Specifically for us, this was for our oncology patients specifically who were either PUIs, persons under investigation in need of evaluation, or patients who are COVID positive in need of treatments. It was, as everything in this resource-limited time, a case-by-case review, and I had to petition for Miss S based on her wishes, her diagnosis of myelodysplastic syndrome, and her COVID positivity to be treated here. It was a wonderful initiative with pretty full hours and staffed by dedicated healthcare providers who were able to wear full PPE and take care of these patients so that people could receive the treatment as we thought was clinically indicated. Now, I will tell you, I had some very serious conversations with Mrs. S and her family as we were trying to do this. All these visits were done by telemedicine, but I shared with them some real-world data as I share here with you. This is from the American Association of Blood Bankers, really showing how dramatic the blood availability was affected in the setting of the pandemic. All of us know that blood has always been a limited resource, but this became true now more than ever. And I wanted to make sure that we were thoughtful about how we approached this for Mrs. S because she was a fairly high blood utilizer. You saw every 10 days, a couple of units for a number of months. She also had fairly recently, probably in the setting of her virus and progressive disease, become platelet transfusion dependent. And so just to show you that during the pandemic, and this is just a snapshot on this date, but the availability of these products was consistently trending down, specifically the red cells in this red line here. And it happened that right at the height when I was trying to decide what to do with her transfusions, We fell into this dip here of when availability was quite low, and something to think about. So you may recall our multiple choice question at the beginning, and I just like to go back to data where I can. Mrs. S had been transfused in the hemoglobin threshold of 9. This had been her community set threshold for quite some time. And we all know, as MDS physicians, patients, other providers, that MDS can cause a decreased quality of life from anemia alone. This was a family who was very data driven, and there has historically been sparse data regarding what is a safe minimal hemoglobin in MDS patients to forego transfusions without any evidence of end organ damage. I was able to use this paper by Goyo Abel and colleagues that looked at expert opinion on this matter. So this was 13 expert MDS clinicians discussing, using a modified Delphi method, what was a minimum safe hemoglobin for this population. And there was 100% consensus at the conclusion of this manuscript and methods that it didn't have to be greater than 7.5 grams. And this was helpful in my conversations, both in the setting of the limited red cell availability, as well as how to modify for Mrs. S and space her out in the context of the pandemic and our availability to transfuse her. Mrs. S had a unique case. I chose her perhaps because she's an outlier, but I think she was also illustrative for me, is that her RNA remained positive for COVID for almost 3 months, with an unbelievable amount of testing required to try and return to her community transfusion center and so forth. We were able to decrease her threshold so that she wasn't as heavily transfused at 9 grams. We went down to 7.5 grams, and she was able to acknowledge that she really didn't notice a demonstrable difference in her quality of life. Ultimately, she became negative and was able to finally go back to her home transfusion center more geographically near to where she lived. But now she even spends less time there with her lower threshold, which I viewed as positive in the end. And I think this was a useful case for me and for our hospital. That patients probably aren't infectious as long as we thought this was early in the pandemic, and that we need to be thoughtful about our use of testing just to meet some metrics. But she's still around and doing just fine now, a number of months later. So moving forward, I don't think any of us would disagree that we've had to rewrite the rules for the care of myelodysplastic syndrome patients, and certainly the AML patients as well. And what has been a positive in this challenging time is that there's been a lot of collaborative efforts throughout the world, learning from colleagues who were earlier in the pandemic course. I have colleagues in Italy who shared their experiences earlier than ours here in Baltimore, colleagues in New York who were initially hit much harder than our city, and it's been really wonderful. And some articles, as the one I reference here, have brought this to the literature, which I think is also very useful. And some things that I hope carry over for MDS patients and others in general is the importance of the patient over paperwork. We here, at least in our oncology center, do have a lot of rules and regulations and paperwork. And some of that had to not be as much at the forefront and just get things done for the patients and keep them safe. It was interesting to see many patients, out of fear of getting COVID, electing to continue supportive care measures or as opposed to start new therapies that might cause them to be more immunosuppressed. I think this was quite true in some of my intermediate risk myelodysplastic syndrome patients. Telemedicine visits were something that I had never done before, and I've really actually enjoyed seeing people in their homes. I had one gentleman who was able to take his iPad and walk me around his farm with his hemoglobin of 7.5 grams, which I wouldn't have gotten to see otherwise, and it's probably going to continue. I do think patients now realize that maybe they don't have to be transfused as much, and they decide what their limit is of tolerability. I think this can have pros and cons, and I've tried to be very mindful of patients that I think might be pushing it too far to the point of danger. And we're continuing to support the caregivers as well when they're not able to be in the visit. This is the new normal. This was a particularly nice manuscript by Shaw and colleagues and just showed the new normal of how some hospitals in New York were triaging to reduce the on-site clinical volume and consolidate the practices. We here also have a pre-visit COVID screening, and anyone who screens positive with a phone call on the day prior to the visit is asked to delay. This has been challenging. I've showed you how we separated the COVID patients in our urgent care BioMode unit and are continuing to do so even now. To talk about another more standard case, perhaps, this is a gentleman who may be illustrative of some patients that you've experienced or worked with. A 62-year-old gentleman who had DL5Q. He truly had 5Q minus syndrome, and he'd been on lenalidomide for a large number of cycles, as you can see. He had an early complete response after about 6 weeks, way back when I started taking care of him. I have seen him monthly for years. That was always at his request, and he really liked to see his labs monthly. However, he chose to 100% social distance and still actually has not left his house since March 16th. And he's had everything delivered and always has. I found his concerns to be very interesting at the start of the pandemic because he had always wanted a lot of access to care. Now he wanted to not have any care. We had a lot of telephone visits and several telemedicine visits in the setting of what he should do with this fear of leaving his home. We talked about the drive-through lab. There's also sometimes home care availability for appointments, and we continue to have telemedicine visits. Something that I thought was useful in working with colleagues in pharma is they recognized that patients did have fears about availability of their medicines, and there was an allowable prescription for a 2-month supply with the lenalidomide prescription plan. And so I have a number of patients that I safely felt could receive 56-day supply as opposed to their previous 28-day supply, and I think will continue. And it was also nice to have reassurance from pharma that there were no known or anticipated interruptions to supply or delivery services during this time. But those were things I had not historically double-checked and was pleased to see implemented. So the last case is a more acute patient, and I think she represents a lot of what was hard about treating myelodysplastic syndrome in the pandemic, just as the other two cases, but she was more ill. Those two patients had lower risk disease. This was a younger woman, 46 years old only, with essentially an isolated neutropenia. She had a little bit of past medical history, but her initial marrow showed 17% blasts. Given her youth, I did feel she was an excellent transplant candidate. I actually offered her induction chemotherapy due to the high blast count and the fact that I thought this should be a bridge to bone marrow transplant. She actually declined. She did not feel comfortable being away from her family and isolated in the hospital, which is how we do induction. So we had to speak through other therapies. This was quite early in the pandemic here in Baltimore, as you can see. Amar Zaiden at Yale led this international effort that was really a tour de force of thinking through special considerations for patients with MDS and acute leukemia in the COVID era. And this paper came out a little bit later, but some of the lessons I learned from the patient I'm sharing with you is quite illustrative for this manuscript, and hopefully you guys can take a look at it if you haven't already seen it. But the clinical considerations are related to things we've spoken about. Transfusional support can be infrequent if that is safe and not necessarily initiating myelosuppressive therapy too soon. We've talked about things like the drive-through shot clinic for something like an erythropoiesis stimulating agent. We have tried to consider using longer-acting medications where we can to decrease the frequency of those visits. We here have always used darbepoetin, but it's something to consider, and I know some of our community colleagues switched from perhaps a weekly injection to something that was every 3 weeks. Luspatercept was approved in MDS with ring sideroblast in early April, which actually turned out to be fortuitous, and I have a number of patients receiving this late-stage stimulus of erythropoiesis, and some of these patients are intended to be dosed every 3 weeks, but I've spaced them to 4 where feasible if I can keep them transfusion independent. And I haven't had any patients in whom I have had to lower the dose of lenalidomide to avoid neutropenia, but it is something I assess very carefully in all my patients to make sure they're not any more immunosuppressed than needed. And some of these recommendations are in that paper that I've just alluded to. Coming back to this last patient, certainly hypomethylating agents is something to consider in any patient with MDS. For somebody who has lower risk disease, there is some data that lower dose hypomethylating agents for lower risk disease could be given for a fewer number of days or to space out the cycles if we thought that was clinically safe. Obviously, this is a case-by-case assessment based on the clinical need. I have historically not delayed a lot of cycles. I like to stay on time for my patients, but I have changed things based on neutrophil counts and timing and comfort levels during the pandemic more than ever. And subcutaneous administration is certainly faster than an intravenous infusion over an hour of something like azacitidine. And so there are patients that switched from an IV to sub-Q or were already getting sub-Q to facilitate shorter healthcare interactions. Also, since the pandemic, we now have an oral hypomethylating agent for the first time. And this is something that can also keep patients out of the clinic a little bit more. We do believe that hematopoietic stem cell transplantation should be done in cases of higher grade myelodysplastic syndrome. And that's where this particular patient is very key. We didn't have any clinical research during the pandemic. Most of our nurses were deployed and trials were on an individual basis, and there was nothing for which this young woman was eligible for. We made changes for our pre-BMT testing. All of the inpatients were tested when they were admitted. Some patients didn't love this, but we thought it was important. You can see here how we handled our patient donor for BMT. They were always swabbed prior to the patient starting PrEP, and the same went for the recipient. And this was also done in an outdoor setting here during the pandemic. Something that is specific to transplant and myelodysplastic syndrome, I'll show you briefly here, that some centers have always done cryopreserved marrows, but during the pandemic, this was studied rigorously to make sure that it was safe. And even though the post-thaw CD34 count did change the cell recovery and bioavailability just a little bit, as you can see by the line, it still was very acceptable. And so in this context, all products from the CTN for transplant were cryopreserved so that it could make sure that both the patient and the donor did not have COVID prior to considering transplant. Here's the reference there, and it's been utilized quite heavily in large volume transplant centers. So tying back up to our patient, she did refuse induction. As I showed you, our clinical trials were unfortunately not as I would normally have had our portfolio, so she wasn't eligible for any of those. She actually was also failed by hypomethylating agents, and ultimately I was able to talk her into induction. She was able to have a transplant from an unrelated donor, and she's doing really, really well. The interesting turn of fate is after we had gone through all this, just this fall, she had a college-aged daughter who got COVID herself. The patient didn't get it, and the patient and her daughter are well, but what she had been most concerned about did happen in the end, which is something we're all seeing in the pandemic. So to tidy up, we are continuing to ramp back up, as I'm sure you all are. We're giving a lot of flu shots. Clinical research is coming back up, but as you all are, we're still continuing to see ramifications well into 2020. So I provide here some references from trusted sources. I showed you a picture from the Hopkins coronavirus site simply because I use it here, but I use the CDC quite frequently as well as the others that you see. The American Society of Hematology, while we're all at this meeting, also has a lot of guidance. And I think a good research effort is the ASH Research Collaborative for the COVID-19 registry as well. And I encourage you to register your patients if able. So in summary, I hope I've shown you what you all knew, that the pandemic has affected individual patients with MDS in particular in different ways. We're continuing to be attentive for both COVID and the flu now that we're here in the winter. And I'm trying to push forward with my patients to ensure clinical trials are back up so we have really good options for them. And I'm continuing to encourage blood donations so that the supply is not limited. So I appreciate your time today. I'm grateful to all of you for listening, and then for the patients and families and all the clinical teams and research teams and support I have back home. So thank you so much, and I'm happy to take your questions.